Welcome, my dear colleagues. This is Dr. Mustafa Mahmoud. Today, we will continue to present other member of glucagon-like peptide 1 receptor agonists family, which is dulaglutide or trulicity, and its role in treatment of type 2 diabetes and prevention of cardiovascular adverse events. Please don't forget to like and subscribe to my YouTube channel for more video updates. What is dulaglutide? Dulaglutide is an incretin mimetic analog of human glucagon-like peptide 1. The drug is a recombinant DNA-engineered polypeptide. The analog portion of dulaglutide is approximately 90% homologous to native human glucagon-like peptide 1. The engineered drug differs from native human glucagon-like peptide 1 that had larger size and resistant to degradation by dipeptidyl peptidase 4 enzyme, which reduces its absorption and renal clearance. Those features result in soluble formulation and prolonged half-life of 4.7 days, which makes it suitable for once-weekly subcutaneous administration. The drug improved glycemic control through sustained effect of lowering fasting, pre-meal, postprandial glucose concentration in patients with type 2 diabetes. Mechanism of action of dulaglutide to achieve glycemic control. In patients with type 2 diabetes, impaired insulin response to the native glucagon-like peptide 1 hormone, possibly related to a reduction in postprandial glucagon-like peptide 1 secretion. Dulaglutide acts as glucagon-like peptide 1 receptor agonist. Those receptors found in pancreatic beta cells. The activation of those receptors increases intracellular cyclic AMP, which increases insulin secretion in the presence of elevated blood glucose levels. On the other hand, glucagon-like peptide 1 receptors are found in pancreatic alpha cells. Dulaglutide acts on such receptors and suppresses inappropriate glucagon secretion post meals. Also, glucagon-like peptide 1 receptors are found in gastric mucosa. The activation of such receptors by dulaglutide leads to delayed gastric emptying, to decreased postprandial glucose and decreased food intake. Such actions working collectively to achieve glycemic control. Indications of dulaglutide. Dulaglutide is indicated as once-weekly subcutaneous injection adjunct to diet and exercise to improve glycemic control in adults and pediatric patients equal or more than 10 years of age with type 2 diabetes. Also, it is indicated to reduce the risk of major adverse cardiovascular events in adults with type 2 diabetes and establish cardiovascular disease or multiple cardiovascular risk factors. Although dulaglutide is indicated for type 2 diabetes, it is prescribed off-label for weight loss in those with overweight or obesity. Doses of dulaglutide. Initial dose of dulaglutide is 0.75 milligrams subcutaneous once weekly. If not meeting glycemic goals after 4 weeks, increase the dose as tolerated every 4 weeks as follows. 1.5 milligrams subcutaneous once weekly, then 3 milligrams subcutaneous once weekly, and finally 4.5 milligrams subcutaneous once weekly. Because dulaglutide is presumed to be degraded into its component amino acids, No dose adjustment needed for hepatic or renal impairment. Contraindications of dulaglutide. Dulaglutide should not be used in patients with history of pancreatitis, patients with type 1 diabetes, or in patients with personal or family history of medullary thyroid carcinoma or multiple endocrine neoplasia type 2. The adverse effects profile of dulaglutide is similar to other glucagon-like peptide 1 receptors agonists. By system organ class, on immune system, hypersensitivity reaction is uncommon. Anaphylactic reaction is rare. On the metabolism, hypoglycemia is very common when combined with insulin, glimepiride, metformin, or metformin plus glimepiride, while common when combined with metformin plus bioglitazone, or when used as monotherapy. Dehydration is uncommon. On GIT, nausea, diarrhea, vomiting, abdominal pain are very common, but decreased appetite, dyspepsia, constipation, abdominal distension, and GERD are common, while acute pancreatitis is rare. GIT adverse effects are decreased in frequency with continued use. On hepatobiliary, cholelithiasis or cholecystitis are uncommon. What is the clinical evidence and efficacy of dulaglutide for treatment of patients with type 2 diabetes? Here we will summarize most of the available clinical trials about the clinical evidence and efficacy of dulaglutide. The first group of trials evaluated the efficacy and safety of dulaglutide as monotherapy or combined with other anti-diabetic drugs compared to placebos, insulins, or other anti-diabetic drugs. In Award 1 trial, both doses of dulaglutide achieved statistical significant reduction of hemoglobin A1C than exenatide. Regarding weight reduction, patient lost weight of 1.3 kg with 1.5 mg dulaglutide and lost weight of 1.07 kg with exenatide, but gained weight of average 0.2 kg with 0.75 mg dulaglutide and placebo. In Award 2 trial, 1.5 mg dulaglutide showed significant better hemoglobin A1C reduction than insulin glargine, but 0.7 mg dulaglutide showed comparable reduction to insulin glargine. Regarding weight reduction, both dulaglutide doses showed significant weight reduction than insulin glargine. In Award 3 trial, dulaglutide produced significant better glucose control than metformin. With 1.5 mg dulaglutide, hemoglobin A1C was reduced by 0.78%. With 0.75 mg dulaglutide, hemoglobin A1C was reduced by 0.71%, while with metformin, hemoglobin A1C was reduced by 0.56%. Regarding weight reduction, 1.5 mg dulaglutide was non-inferior to metformin. In Award 4 trial, dulaglutide produced significant better glucose control than insulin glargine. With 1.5 mg dulaglutide, hemoglobin A1C was reduced by 1.64%. With 0.75 milligram dulaglutide, hemoglobin A1C was reduced by 1.5%. With insulin glargine, hemoglobin A1C was reduced by 1.41%. Regarding weight reduction, body weight did not significantly exceed that at baseline in the dulaglutide 1.5 milligram group, while common side effect of insulin glargine was the weight gain. In a 5 trial, hemoglobin A1C was reduced by 0.99% with 1.5 milligram dulaglutide, 0.71% with 0.75 milligram dulaglutide, while hemoglobin A1C was reduced by 0.32% with sitagliptin. Regarding weight reduction, 1.5 milligram dulaglutide achieved a greater reduction of weight than sitagliptin. In a 6 trial, once weekly 1.5 milligram dulaglutide was non-inferior to daily 1.8 milligram liraglutide for hemoglobin A1C reduction. Regarding body weight, weight loss averaging 2.9 kg with dulaglutide and averaging 3.6 kg with liraglutide. In our 7 trial, patients with type 2 diabetes and CKD taking either doses of dulaglutide achieved similar glycemic control to those taking insulin glargine, but had significant less decline in the renal functions. The estimated GFR declined by 0.7 milliliter per minute per 1.73 square meter with dulaglutide, while declined by 3.3 with insulin glargine. Regarding weight reduction, body weight decreased with dulaglutide but increased with insulin glargine. In our 8 trial, patients with type 2 diabetes on glimepiride monotherapy, the addition of 1.5 milligram dulaglutide was associated with significant hemoglobin A1C reduction compared to placebo. Regarding weight loss, the difference between the two groups was non-significant. In our 9 trial, dulaglutide as add-on to glargine rather than as replacement for it as in our 4 trial resulted in significant reduction of hemoglobin A1C and body weight compared to placebo. In our 10 trial, patients with type 2 diabetes taking sodium glucose cotransporter 2 inhibitors with or without metformin, the addition of dulaglutide resulted in significant hemoglobin A1C reduction than placebo. Regarding body weight, weight reduction was significant with 1.5 milligram dulaglutide compared to placebo. The second type of dulaglutide trials evaluated the cardiovascular outcomes, which made dulaglutide gained FDA approval for reduction of major adverse cardiovascular events in adults with type 2 diabetes who had established cardiovascular disease or multiple cardiovascular risk factors in the REWIND trial. In this trial, the primary composite outcomes of non-fatal MI, non-fatal stroke, or cardiovascular death occurred less frequently with 1.5 milligram once weekly subcutaneous dulaglutide compared to placebo. On the other hand, no difference in all-cause mortality between the two groups. The third type of trials evaluated the efficacy and safety of 3 mg and 4.5 mg dulaglutide versus 1.5 mg in patients with type 2 diabetes who are inadequately controlled with metformin, like Award 11 trial, which showed improved glycemic control and body weight reduction compared with patients taking dulaglutide 1.5 mg at 36 weeks. These improvements were maintained at 52 weeks. The additional glycemic benefit and body weight loss were achieved with a similar safety profile to 1.5 mg dose of dulaglutide. With 4.5 milligram hemoglobin A1C improved by 1.9% and body weight reduced by 10.4 pounds from baseline. With 3 milligram hemoglobin A1C improved by 1.7% and body weight reduced by 8.8 pounds from baseline. Both doses showed significant reduction in hemoglobin A1C and body weight compared to 1.5 milligram dulaglutide, with a similar safety profile. At the end of our presentation, our take-home message that dulaglutide is glucagon-like peptide 1 receptor agonist licensed drug and indicated as once-weekly subcutaneous injection for treatment of type 2 diabetes and prevention of cardiovascular disease with secondary weight reduction outcomes.